We're going to see some similar concepts that we just discussed in our battle, but now instead of just hearing from a couple people, we'll get to hear from 4. So I have sort of 5 topics that I sort of chose for this, all primary cases, nothing tricky. So we're going to talk about approach. We'll talk about fixation strategies. We'll talk about unilateral versus simultaneous bilateral hips. We have one thing in there about dysplasia, just to get your thoughts on that, and then we'll spend a great deal of time on how we approach the hip spine syndrome patients. So, all right, disclosure the same as yesterday. So we'll start off with this one. This is a 68-year-old healthy female with right hip osteoarthritis. So approach for this one, let's just go down quickly. Are you single approach? We'll start with Carlos, or do you tailor it to the patient?
Yeah, I'm single approach, posterolateral for everybody.
Okay.
Yeah, mini posterolateral for me.
Mini posterolateral. Alfred?
So posterolateral and some DA depending on habitus.
Okay.
And then for me, DA 99% of the time.
Okay. Anything on these x-rays that are concerning or anything? You're going to stick with your primary approach, right? Alfred, you change approaches based on body habitus?
I do, again, thanks to Jeff and my other partners.
Okay, all right. So I'm primarily an anterior-based surgeon at this point, 99%. So this is a DA approach for me, a little bit older case, so a collarless implant. So what does the data suggest? Carlos, what do you, before we get into a, not really a great paper, but a meta-analysis, I mean, what are you telling your patients about the data when they ask you? They're like, well, my friend had a DA.
Yeah, the true disclosure, I lose patients because I don't do direct anterior approach. I probably 20% of patients that come to me for different reasons end up having surgery with one of my partners. Because as you just said, they have the family member, neighbor, whatever, that had a good result and they want to resemble the same result. I explained to you what was my journey, and I can share that with you. I actually was one of the first ones in my practice to start doing anterior approach when this was just being popularized by Joe Matta and others. That was kind of like the first iteration of direct anterior. I was doing tableless. I trained with Eric at the Rothman Institute. Had really no issues. I have to confess, though, that it was stressful. I had to be there, and I usually run 2 rooms. I always have to be there because if you lose the interval, miss the interval, whatever else happened, it is harder to recover. And yet, 3 years into practice, the data, level 1 data from Mayo Clinic, HSS started to come out, and they just show that it was a very small window of faster recovery at the expense of more complications, more blood loss, more neurovascular injury, more periprosthetic fractures. And I actually had one of those complications myself, and I was like, what I'm doing? I mean, as I told you yesterday, what I would do if it would be my mother. And I said, I want to have something that is reliable and safe, and that's when I went back to posterolateral, and I haven't gone back since. But again, I think that it depends on what you're practicing. And in truth, I have been in some of these debates many times, anterior versus posterolateral approaches. You know, there are many iterations on the data, and not to mention, we never take into consideration all the conversations that we have had since yesterday. We always talk about the implant, we always talk about the patient, right? Oh, it's because the patient had an elevated BMI. Oh, it's because this implant. But we never talk about the surgeon. Very few studies. I mean, we talk about a little bit about the learning curve, but in truth, we don't really have an objective way of tell how we do, how good we are. But everybody in this room know who you will send your family members to. So that's something that we have to take with a grain of salt. My personal opinion today is that if someone asks me about this, should I have a posterior or anterior, I would tell them, forget about that. look at the surgeon. If a surgeon has good experience, have been doing this for a long time, and had good results, regardless of doing it from the back or the front, that's the most important thing.
Carlos, it's really refreshing to see somebody else that's actually tried the anterior and abandoned it. Because I certainly did that, did 400 of the anterior, and the complication rates were too high. And they didn't the outcomes did not justify the increased complications.
I would sort of echo what Carlos has said, and being an anterior surgeon, I actually almost verbatim say what Carlos says when they come and see me because they want an anterior surgery versus a posterior surgery. I tell them that's not why you're seeing me. So I'm happy to take care of you, but you have to just trust your surgeon and trust how they're doing it their best way possible, because the data, at midterm follow-up, or it's a very incremental improvement in that very, very short time, and after that, it's a wash. So I think as long as the surgeon is safe in doing what they're doing, it's important. I will tell you, from personal experiences, the one thing that I have maybe a knock on anterior approaches is that, especially in those patients who are a little fluffier, when I tend to make my incision much more lateral so I can stay out of the pannus, but you can still have an issue with that proximal centimeter of the incision. So you got to be just very careful and meticulous with your soft tissue handling, especially on those patients. But yeah, I quote them the same data that you're showing here, and patients still wanted to have it.
Yeah, I mean, we could spend an hour on this going through all the articles. This is just a meta-analysis. It's dated, it's old, but yeah, I find it interesting. I'm glad that we have differences. I trained here. I didn't do any DA until my chairman, 3 years into practice, demanded that one of us change. So I jumped on it, and yeah, the first 4 years were miserable, but now, I'm okay with DA. So, all right, we won't. Yeah, go ahead.
If I may add, I think that more important than the approach, in my opinion, the true advantage of an anterior approach is the fluoro. Is having an objective way to tell you where you're landing, particularly with the acetabulum, and actually with the femur too. I mean, it gives you a better idea where you're at in terms of your broaching, et cetera. So it gives you objective data. If anything, that will be the main reason I may change, is just because the same thing that I did with robotics 6 years ago, I was like, this is never going to help me, and I believe today that I was wrong. I have a better objective data, and I don't have that many assumptions. I mean, I often, when I see my postoperative x-rays, I'm like, oh man, I thought that I was, in terms of length or position of the cup, I made assumptions that were wrong.
Yeah, that's a good point. I mean, I think the comfort level of having fluoro in there to guide you. I found this paper when I was trying to prepare this rather interesting. I'd never seen this one before. Dislocations, I think, very rare now, events, but if it does happen, this would maybe be in favor of saying if you went from an anterior-based approach, the likelihood that you could potentially treat that conservatively or repetitive dislocations is a little bit lower. I don't know. One single study out of Canada, but I found this a little bit interesting. All right, so let's move on from approach. This is a 79-year-old female, so we're going to focus on fixation here. She had her right hip done somewhere else and came and saw me and wants a left hip replacement. And so we sort of went through approach. We talked about fixation earlier. So let's go down the line here. Let's start backwards. Nader, you're DA.
Yep.
Are you cementing this? Cement this?
I would. From the front, I mean, this is a game time decision. You can see her canal's kind of capacious. She's like probably like a C- there. She's 79 years old, likely osteopenic, if not osteoporotic. I think, given the data, I would discuss with her cementation, and I would have both available, but likely cement this one, and I'd have no problem cementing it from the front.
Yeah. Alfred?
Same approach. I probably would go posterior, depending on how big her belly was. And it would be game time. I'd have no problem putting in broaches, seeing if there's adequate stability, and very, very low threshold to cement.
So let's pause there for a second. The game time decision. So we're all busy. You have 2 rooms. What do you mean game time? Like okay, I'll open up the cement. Well, it's not there. And to our point earlier, like, where's the restrictor at? Where's the pressurizer? So what do you guys think about that? I mean, Do you really game time? You're not just going to tell the room
It's in the room.
exactly what
it's,
you want?
It's there. It just, as after the femoral neck cut, as I'm preparing the acetabulum, they're opening whether it's set up for one, and if I need to change, they can do it before I get to the femur.
I think it's
Speak
not that
for
big a deal.
yourself about efficiency and number of rooms and who you're working with.
What about you? What about you? Tom?
It would drive me crazy to make the decision on game time. I'd want to make this decision ahead of time. I would do it uncemented in this particular
Uncemented.
patient. But yeah, I mean, I am ready to cement if the case, demands it. If this was a 90-year-old, I would be cementing that.
She's
But,
close.
No,
79?
she's 79.
Carlos, are you?
Depends how active she is. I'd assess the patient.
I have to tell you, one of the best changes in practice I have done is that I really decrease my threshold to cement. And I make that decision where, even, if you bought it, you bought it. Same thing that switching from a uni to a total is not a good way to manage resources. So I will do cemented, especially females older than 70, more than 90% in my hands will get a cemented femoral component.
Yeah, same here. I mean, I try to make the decision. I think we're all kidding ourselves. I think if we leave the decision up to game time, we're probably going to be doing cementless stems in people that we probably should not, because we're like, I really don't want to wait for the cement, and the other room's ready, and I want them to roll back. So I try to make the decision ahead of time. My shop, they do have it. They have it open. They have the restrictors in the room, so you don't have to open up doors, reps going in and out all the time. So I think we went through a lot of this literature earlier, but one article on the left from the Hip Society this year, it was a retrospective review, but I mean, it's without a doubt, all-cause revision is lower in cemented stems, and especially in a female that's over the age of 70. It's not debatable, really. Right? And then you look at the German registry study, bottom line, cementless stems in these high-risk groups, the mid-3 group, which our patient is in, darn near above 80, it's fine. They do better, right? No?
I mean, if I may add, like earlier we have a discussion about the logistics of cementing, but I think that you just have to just make the decision. And that's what we did as a group. We just basically said every female older than 70, we're going to cement. Every femoral neck fracture, we're going to cement. So the team already knows, if that's what we're having on the table, they already have 2 bags of antibiotics, and we do it all the same to avoid those issues, and that has increased efficiencies and time and so on. And I'm really glad we did. I mean, we have looked in the last 6 years, our periprosthetic fracture has decreased probably 80% in our group because of this.
Yeah.
And I'll give you one silly thing that occurred to me last week when I booked an uncemented hip in Epic, because that was the only procedure I could find. We didn't have the hybrid hip anymore, and therefore the consent was an issue because it said uncemented hip, and I was doing a hybrid, and the nurse wouldn't let me get in the room without redoing the consent, which took a lot of time and effort.
Really?
Yes, and so that's just one other minor thing that we run into occasionally.
So I was facing this way, but for the clinicians in the audience, who was cementing hips sometimes again? How many? Yes, a lot of us. Good. Okay. Yeah, I mean, one of my mentors in residency, I mean, he cemented Exeters in. I don't have the skill set to do that anymore. That's a hard surgery to cement an Exeter. I've thought about using that stem, but I don't want to relearn how to do that, especially from an anterior approach. You got to hold it, and it's moving. And okay, this is a 63-year-old female. Happens to be the ex-wife of a owner of a professional sports team. She's traveling all over the world. She's motivated. She has things to do. And her question for you guys, we'll start with Tom, is I don't have enough time in my schedule. I want them both done at the same time. So bilateral, simultaneous, staged. What are your thoughts here?
I'm doing the mini posterior. I rarely will do bilateral, and it has to be the right patient, and I'm going to assess them in my best psychiatric manner to know how motivated they are as a patient and whether they have good pain tolerance. I don't know how I do that. I just look at the patient and talk to them and say, hey, it's about 1 in 10 that might be a candidate I will do, and it really depends on my assessment in the clinic, and I can't tell you any better than that. I'd love to start doing grit scores on all these patients to understand what their grit is and how they can survive through it. But I would generally, most of the time I probably do unilateral, but I have done bilateral.
Okay. Alfred?
So,
It's a unique patient for the VA, but,
yeah, very healthy, motivated. So basically, I'd probably do bilateral simultaneous DAs
Okay.
after discussion with her.
And so how are you counseling that patient, Nader? Risk,
Yeah.
simultaneous, bilateral. What are you saying?
So, I mean, the data is, you can pick whatever papers you like. Some show increased risk, some show equivocal risk, but I favor staging these. I prefer to do one side versus the other side. So I talk about increased blood loss, risk of DVTs, PEs, and I use that mostly to try to dissuade them from doing the hip replacement simultaneously. The patients I do simultaneous replacements, whether knees or hips, are usually young male laborers who are the sole providers for their family, who I think really do need to get back to work.
Okay.
But other than that, I try to counsel them out of it, and pretty successfully as well. So I dislike bilaterals.
Anything to add, Carlos?
No, the only thing is logistically requires some additional support, right? You need to, I never use one table. We use separate tables. I'm always concerned about the risk of infection. This is really my only indication to do DA, and I usually do one of my partners. We have the conversation about Cell Saver for the blood loss, and we have the conversation also about DVTs. Even if it's healthy and everything else, we actually have had a couple of patients that have PEs. Actually, we have one death on healthy young laborer. So I think that logistically you have to plan it well. And the other thing that I will mention is we do one side, took everything out, and what they are making the changes and prepping the other side, go to the other room. I do one case, and then I come back and do the other side.
Okay.
One other thing that I think we ought to consider here is, are you doing these all same day? I think most of us are doing same-day surgery. You could do same-day surgery easily on one. You're not going to do that on both. I don't like patients in the hospital, so
Yeah.
I'd rather do. My bias is one.
Yeah. I mean, she talked me into it. I mean, she has trips to Europe and things, and she actually saw my partner, and he said no. So then she said to
That's
me,
easy.
I mean, yeah. So we did do simultaneous bilateral DA.
Craig,
Yes.
what is your discussion with them as your, in terms of risks?
Yeah, I mean, I tell them, I think, like Nader said, we can pick. The beautiful thing about orthopedics, and we've seen it this weekend, is that literally we can argue any side of anything because we live in this level 3, 4 world.
Right.
So I tell them there's an increased risk of blood loss, risk of transfusion, thus subsequent, I think, increased risk of infection for sure. I try to also not do simultaneous bilateral surgery. I'm more lenient with hips because I think they just recover easier than knees. I hate doing bilateral knees. This, systematic review published a couple years ago, demonstrated, actually a reduction in DVT with simultaneous bilateral and complications. But I think the way that they looked at this one, it was 2 different episodes, right? So for those that are staging, what's the interval in between?
Minimum 3 months.
3 months?
Depends. If they have a hip flexion contracture or other issue, I'll do it with a month later. And if it's a really motivated patient, I'll do it a month later, but usually 3 months.
3 months, typically.
Yeah. I mean, Tom, you're probably the only one up here. I mean, maybe you were around when, they were doing staged bilateral knees, like one week and then one the next week, keeping the patient in the hospital. And that was a disaster, right?
The biggest disaster was actually the design of the implants, where when I started my career, we were doing bilateral total knees and admitting them to the ICU because the incidence of fat emboli was 20%. And so that was, and for those of you who don't know the design change, it came with the flutes in the guidance system for the distal cut.
Yeah.
It used to be solid, and that's what caused all the fat emboli.
Yeah.
So.
Okay. So I brought this case just to sort of get the panels. Let's talk about sort of how we approach a little bit more of a complex primary situation. This is a 40-year-old with congenital dysplasia. Saw the sports people. They don't want to do anything, obviously. Carlos, do you want to start with this one?
Sure.
What are you thinking in this case?
The main issues are to reestablish the mechanics of the hip. So the center of rotation has to be reestablished well. I have a low threshold on this and use some sort of aid to have more objective data. Like in this case, I will do robotic-assisted surgery, again, because it has to be perfect. One common mistake on this one's, again, for some of us when we have 2 rooms, is how the reaming. This one has to be done really well. You have a thin anterior wall, and it's very easy to elevate the center of rotation and just ended up with a big cup that it overhangs anteriorly. So for that reason also, I would like to plan my surgery with having some sort of more objective data. In this case, robotics surgery gives me a CT scan. I know the sizing, and often if I need something on top of the cup, can I just have a leeway just with a little bit of bone or larger cup, that I go bigger A2P. I try not to use dual mobility in younger patients. But it depends. It is hard to assess the soft tissues, especially when you have a valgus, like this plastic valgus female with almost no offset. This is a patient that has a really high risk of instability. One of the other things that I'm going to tell this patient is that it's very likely I'm going to lengthen her. So I'm going to make her legs a little bit longer, putting more tension in the soft tissues to help me with stability. And also, it's not uncommon that I may have to change her offset a little bit, and we have a little bit of discussion about trochanteric bursitis and things like that, especially if it's a female thin. Usually these patients are kind of like athletic and things like that. So all those things are concerns that I keep in mind. You show the spine also. And I'm not sure if you have another case where we're going to talk about that, but for all these reasons.
We'll get into the spine stuff, yeah.
But for all those reasons, I think that the robotic assisted will allow me to perform a better surgery.
Okay. So the concept of establishing the true hip center, I think, is important, right? Nader, you're anterior all day on this one?
Yeah, all day. I think this is where an anterior approach with fluoros actually can give you a big advantage here. Really getting the hip center down to an anatomic hip center. She doesn't have a lot of bone loss, so we can certainly get her down and medialized. She doesn't have a lot of offset here, so I think with the anterior approach, you'll be able to dial in the at least the leg length. I agree that you might have to increase her offset a little bit. But as I teach my fellows, low and slow, really start small and build up, and so that way that we're paying attention to the anterior wall. Other thing to pay attention to is the femoral version in this one. She probably has a little bit of neutral version, so you have to be mindful of that when you're putting your acetabular component in, and you'll be able to get it in a good position. So anterior all day on that one.
Yeah, I agree with everyone. I would say that when you're looking at radiographs, just be careful that your actual varus valgus as well as abduction adduction is highly dependent on your projection.
I would say just a couple things. First, I don't see a magnification marker on this x-ray, so I'd send the patient back to x-ray and say, I got to get, because I want a good template on this. I want to know where it's going to go. And the only other thing I would say technically is I would normally, with most of my hips, start 4 millimeters under my template, which is carefully done. But in this case, I'd start lower so that I could really monitor where I'm going to place that cup and take it slow and easy, as Nader said,
Okay.
and really have a good look at it.
Yeah.
And there's plenty of medial bone. I think there's room.
Yeah.
Oh,
It's
for
just,
sure. Yeah. This is not a slam bang acetabulum. You got to really slow it down when you're doing this
Yeah.
one. Especially how young she is. You don't have a lot of room for error.
Okay. Yeah, I mean, you guys brought up a lot of concepts. I mean, let's just quickly, I think we got plenty of time. Are you a combined version Ranawat type person? Are you a anatomic type person? I guess it would be dependent on approach, but this person likely has, excessive, obviously, anterior wear of her socket, so excessive anteversion on her socket, most likely. Are you going to allow for some cup to be exposed up front, rubbing on the psoas? Are you going to just match that?
Yeah, for these, I'll try to medialize. I almost medialize to the medial wall, if not a little bit past that, if I need to get that coverage. I mean, patients, especially anteriorly, are really sensitive to iliopsoas impingement, so I'm going to try to get that anterior lip of the cup right at that wall just to minimize that, and then I can make it up on the femoral side. Obviously, when you're going in, you're seeing what your natural version of your implants look like. There's not a lot of room to give, but there's a little bit of room that can compensate for it. And I'm more anatomically based. I can't do a Ranawat test from the front.
Yeah.
Yes, from the front, I would say, again, anatomic, also checking to see if there's overhang of the component anteriorly, medializing or changing version if needed. From the back, Ranawat, as well as range of motion to impingement.
And I use the Ranawat entirely, but one thing I will almost always do in these cases of DDH is have a SROM prosthesis available, because I love to be able to dial in the version if I need to.
Femur first? Anyone? Or you look at it, you're like, oh, the femur's 30 degrees of anteversion is what she has.
So, not in this case in
Okay.
particular. I don't think that this case,
Pretty mild.
my sense is, it will be straightforward. But you have like a Crow 4 or something like that. Yeah, definitely, because I have a better idea. If you're doing a subtrach osteotomy or something like that, I actually have changed from the SROM to a Wagner type of stem.
Yep.
It feels that it's a little bit easier, the whole surgery, and it gives you the whole freedom for change of version. Yeah.
Okay. Yeah, I mean, it was pretty straightforward. It was, for me, it was DA, careful reaming, just like we talked about. You can see she's fluffy, so the cross-table lateral post-op, we can't even see it. I did lengthen her a little bit. I tell them that as well. I think people tolerate it very well, especially if you tell them beforehand. I don't, to Claudia's, or to one of the talks earlier, I mean, these stems don't fit everyone's anatomy. We don't have a stem that has a femoral neck angle of 140,
Right.
of these valgus, so a little bit of increased offset. I think I just put this up here for people it's a really good review from the group out of Utah. Really highlighting everything that you just heard here. So this is a mild dysplastic case. I mean, for people that are just getting into practice, fairly straightforward. But you got to be prepared. You got to understand that there's a varying degree of problems. Yes, sir.
I got a question regarding a technical aspect. What kind of tricks do you guys use to put your anterior retractor while you're doing anterior approach in these very deficient anterior walls?
The anterior retractor?
Uh-huh.
I'll typically just cheat a little bit more superior, so it's much more on the superior rim rather than truly like medial where I would go. So, and it has not really been an issue. And most of my anterior retractor typically sits on sort of, if you're looking at the hip, at like 1 o'clock rather than 2 or 3 o'clock.
Anything else?
I guess I have a follow-up question. So in revision settings where the bone is mush and there's not much bone there, how do people deal with those anterior retractors?
Yeah, we'll discuss that at lunch. Yeah, nothing too different. I actually tend to cheat my anterior retractor. So for this right hip, I'm actually not going to go superior. I actually cheat it a little bit lower or inferior medial. I think JBJS, there was a great cadaveric study a couple of years ago looking at all the dangerous stuff that we can hit with our anterior retractor. A good review for anterior-based surgeons. What about you? What do you teach us? What do you do?
I can share just one thing that I learned the hard way is now we're using something that is called the grippers that holds the anterior retractor still. But when you're working with someone who is holding the retractor from the other side of the table, sometimes the retractor falls. And then you have to take it out and then reposition it again, because the mistake that we made back in the day is we did this, I repositioned it, and I hit the artery there.
And the other question
And
I
we
would
find
have,
out in PACU, actually.
That's not a good day.
no. The other question I have for the panel is how many people routinely, carefully checked for femoral nerve palsies, partial and total?
Post-op?
For anterior
For an
surgeons?
anterior surgeons putting that
good.
retractor.
Okay, yeah.
I
What do
mean,
you-
I haven't seen many papers where they specifically address femoral nerve issues.
Well, we always check post-op their femoral
that?
nerve activation. We check quad function after post-op.
Yeah.
Every patient. One thing, though, I would say for regarding that, so my retractors are in only during acetabular exposure and cleanup. Once I've cleaned up the fovea, I've cleaned up the labrum to the best of my ability, then I will take all my retractors out and I'll put in a Gelpi, a long, deep Gelpi that goes inside the capsule just to keep it open. I think that the more retractors you put in, the tighter the hip comes and actually makes your acetabular preparation harder to get your femur in and out, because it's going to proximalize your femur more. So less retractors are actually better when you're doing your femoral preparation.
Yeah. Okay. Yeah, I mean, we did have to teach, or I did, and even the junior residents now when they come on service, that no one checks the femoral nerve, and I teach them that. Yeah, we got to check. Yeah, go ahead.
And if I may add, this is pertinent to dysplasia, not for this case, but severe dysplasia when you're lengthening them more than 1, 2. I mean, the classic thing is 3 centimeters, but actually I have had nerve palsies just with 1 centimeter of lengthening. But if I look preoperatively and I know that I'm going to have a significant lengthening, even in a revision case, I often, depending on the type of stem or instruments that I'm using, I always have another set of instruments ready. Because what we have done in the past is we don't use nerve monitoring anymore. What we do is we let the patient either wake up a little bit and see if there is really a nerve palsy or not. Or if we pick it late in PACU, then we take the patient back right away. We don't wait. And actually, we have had really good result with that. Basically, we have had like 6 or 7. We want to kind of write a case series on this, where we take them right away, we shorten them. But the problem of doing that, if you don't have the instruments, then you cannot do it right away. Then you have to wait. So that's for those reasons. If we know we're going to do significant lengthening, we have them available, and we take the patient right away and we shorten them.
Yeah, this is the big Crow 4s you're talking about. Yeah. Alfred?
So shortening as an osteotomy, or shortening as, because
Well, whatever.
you presumably
Sometimes it
have your
depends. It
soft
depends
tissue
on
tension.
It depends on how it is. Sometimes you just need to change the head. It's just some millimeters. Sometimes you have to change, if it's a modular, you have to change the entire modularity. Sometimes, you have to go big and then really remove 5 millimeters more of bone or something like that. But
All right. So now I'm going to show a few cases sequentially. We have about 20 minutes left, and we're going to talk about hip spine stuff. And I'm not really going to, we have a couple articles at the end to look at, but So this is a 78-year-old female, right hip osteoarthritis. We can see a little bit on the picture on the right. There's something up in the spine. That's what she has. A single level fusion, degenerative changes, 78. So let's, I'm going to go through these cases. So I didn't really change anything that we've already talked about. I did this from the front. I cemented her stem. I did not use any different articulation. But let's go to the next one here. 74, very, very sick. And her daughter's the CEO of our pediatric hospital on campus. So let's start with Alfred. What else do you want in this patient? She's obese. What's your workup? Are you getting...
So I'd like to see her spine, and honestly, I don't understand spinopelvic
There's her spine.
mechanics necessarily. They're all these radiographic measures you can do, but even understanding that, she's at a high risk of dislocation. What can you do to mitigate that? I don't know that we understand it well enough in terms of component positioning. If we do, I'd love to learn about that, which leads us to our implant choices, right? So obviously putting it in the right place, whether you assess that anatomically or by assessing range of motion, RONA, whatever, and considering larger articulations or alternatives such as dual mobility in someone who's relatively, 74, it's not a 40-year-old. I think the unforeseen consequences of dual mobility or wear are probably going to be mitigated in this older patient with comorbidities.
All right, so you're not getting standing, seating, hip, spine x-rays.
Again,
Maybe
I don't
you?
understand it, and I
'Cause you
would
don't
love to
understand
learn more about it if someone understands it.
Tom, are you getting standing, seated, spine
I tend to
x-rays?
agree. I wouldn't, I think I understand the concepts, but I don't know that I can actually apply the concepts effectively.
Okay.
So in other words, I can't really read the x-ray such that I know exactly what I'm going to do with my cup position.
Okay.
What I know is I'm going to make this the most stable construct I possibly can, and that may mean changing the cup position, may mean bigger heads, or it may mean dual mobility, which is a very frequent thing for me in these kinds of circumstances. But it's got to be ultra stable and ultra stable in flexion for sure. And I
So-
flex up more than I normally would do.
So in terms of, I think the discussion of spinal pelvic tends to be very academic, right? So if you look at that paper that was Fedorchik published, and then he puts the recommended, like comfort, like safe zone for a stuck seating or stuck standing position, they're within, they overlap. For me, that doesn't make a lot of ideological sense in my mind. I'm not going to make such a big difference, and it's not going to be the granularity of my or accuracy of my cup positioning is going to be based on clinical findings. So I can't tell you the difference between a 15-degree anteversion versus a 20-degree anteversions reliably, right? That's not going to happen. So I think in general, I'm actually going to quote Jeff on this. Jeff gives, if you haven't heard it, Jeff gives a really nice, very simplified talk of how to deal with spinal pelvic things. So I'm not going to take it. Jeff, say what you always say in the fellows course. No, the quote about just put it in the right spot, with the X-rays.
So I think the takeaway from all of these is basically just get a standing film and then make the cup look 20 degrees anteverted on a standing film. And that's all you got to do. That fixes for the stuck sitting, for the standing, all those things. You find a functional position, which is standing, and make the cup look right, and you will hit all of Fedorchik's little check marks.
All right.
And then the other thing you do is you just do a DA, and they're not going to dislocate. So it's
That was going to be a
To
question.
keep it simple.
there.
It's to keep it simple. There's a lot of machinations here that we don't need.
So interestingly, then no one here, and not myself either, there's no seating, seated and standing films that I get currently. Carlos, you're not getting all that on these? Okay.
I get an AP and lateral lumbar spine just to take a look at their lumbar lordosis,
Yeah.
and to be able to ensure that that's a fixed problem. And then to Jeff's point, I will match my intraoperative fluoro to my AP pelvis and shoot for that target.
Yeah.
Yeah, I think that a great point is the most important film is having a standing pelvis. Then you can really know where your pelvic obliquity is and your pelvic tilt. And having that information, if you see that the coccyx just really overlaps with the pubis, then you already know that patients start to have more of a flat back, and the majority of the range of motion will happen through the hip. So you have to be aware of that. Now, the other thing that we don't talk about with this often is how much leeway you have. In this patient in particular, you have a lot of leeway, in my opinion, because she's older, low activity, and she's obese. So this type of patient, and I always ask them to walk in my clinic. This is a patient that is going to tolerate a lot of leg length. So this is some of them that I tell them ahead of time, the best way that we're going to deal with this increased risk of instability is I'm going to change your offset a little bit and going to give you more leg length. And actually there's some evidence to support that. The challenging patient is the one that you don't have leeway, like the one that you showed earlier, like a younger, usually slim females. Those are tough because if you don't have too much leeway. Dual mobility, I'm always nervous to put in this type of patients. And again, they have to be perfect because they don't tolerate too much change in offset or length.
Yeah. Yeah, and that was our plan. I think approach matters. I can't back that up scientifically that, the guys in New York won't give us that answer, right?
No, but that's a great point. I think that the approach matters because the position of the cup, how much version and inclination you put in, if you do a posterior approach, is different in this patient than if you do it an anterior approach. If you put too much version anterior approach, this patient actually may have instability anteriorly.
Yeah.
So it definitely changes depending on the approach.
Yeah. And we went with a big head. I think that's a 48 cup. And to Ellie's point earlier, at 48 now, I'm putting a 36 in. With my current system, DM is a 38 at that point. So I don't think that was really worth it.
Yes.
One more here. So we sort of talked about the concepts of how we're approaching these preoperatively. Doesn't sound like any of us up here on stage right now are getting all the things and measuring pelvic tilt and sacral slope. But what about this? Anything different? Anything different that we brought up? For this.
The only thing I would say a little bit different if you go back, the arthritis was relatively mild.
This one?
No. There was one that was, no, that one is moderate, sorry. I was thinking of a different one. But the one point I would make is that I often will see patients come into the office with big spine hardware and mild arthritis on x-ray, with just little changes, and making sure that the symptoms are actually coming from the hip and not the spine is critical. And that's just one other point.
Yeah, so I think same topics here. This one, the right side was done a while ago. Small head, small cup. She never dislocated, but she subluxed for a while.
No, and I just looking at this cup, I don't think that is anteverted enough.
Right.
Yeah. Turns out she recovered well. She did okay. The right one's still in there. And then a few years later, we did the left one, and I went DM on that. Yeah.
I have a question for Tom. Tom, how many times do you think we're going to have a failed spinal with this type of patient? I'm really guessing because there's no data to tell us that if this type of patient should go directly for whatever purpose you want to a general instead of waiting 30 minutes or plus.
We have all the data we want, and I tell them, don't even try. And just because I've been there, sitting there for 30 minutes while they're trying, and so I don't have them try.
So I misspoke. I forgot I found this paper. This is the first paper I've seen that's trying to answer the question of does approach matter. Us anterior surgeons are very bullish in our statements that no one ever dislocates, but this was at the Proceedings of the Hip Society a couple of years ago. Small series, only 1,700 patients, only 111 with posterior spinal fusion, but they noted 0 dislocations if done DA versus 4 posteriorly. So probably do what you're comfortable with. We've all seen these. I mean, these are the articles, talking about safe zones. This was a little bit older, and this one tried to look at the rates of safe zone placement and where we're at. And the reality is that I don't think we really know, right? So this one, standing images compared to supine, dynamic changes, 8% risk of dislocation in this cohort, only 139 hips with a pretty high revision rate of nearly 6%. But of those that dislocated, 78% were in the functional safe zone, but when they changed to standing. So these are the things that they started looking at, right? I mean, they're looking at all this stuff, pelvic tilt, sacral slope. We've all read Vodorczyk's articles, and even when he speaks every year at ACUS, I find it hard to understand. Just wanted to sort of see, I didn't want to review all those articles in depth, but so in summary, you're getting standing x-rays in the office and you're really looking at what their functional pelvis position is and then trying to match that.
Yes,
Right.
that's for me. Yep.
Tom, same thing. Yeah. Yeah. Go ahead.
One thing that if you look at a lot of these papers, unfortunately, is that they look at the outcome is instability, and they look at what is the relationship between the spine and the pelvis and the cup position. But that's not it. They never mentioned where the center rotation was, what the leg length was, what the offset was, and we all know that those things have a significant impact on the stability. I mean, the paper that is quoted all the time is that paper from the Mayo Clinic, where they basically said that it doesn't matter if you put your cup in a safe zone and still you're going to have instability. But they didn't assess leg length, they didn't assess center rotation, they didn't assess offset, none of those things. So I will take a lot of these things with a grain of salt. I'll be very cautious because it's all of the above that I just mentioned that have anything to do with stability.
Yeah. I think that's a good point. And I think, we sort of talked about this during the battle too. I mean, DM is a good tool. I mean, I tend to use it a little bit more in these spine patients. I very rarely use it in primaries, but we sort of briefly talked about metal ion stuff. There's been several studies. This is one of them, sort of looking at that. Out of 127, 21 patients have metal ion testing. Interestingly, they did have a slight elevation in cobalt, but their MRI was pretty benign. So I think it's safe to use modular DM right now, as you guys discussed earlier.
Well, we don't have the real long-term follow-up yet, so it still makes me nervous. But.
Yeah.
Yeah, I'm not a DM user, so I just want to put it in the right place. And I would say to Eli's point, if I'm going to try something, it's going to be a larger head first with a 40 over a DM.
Okay. Well, we're about 5 minutes early, so thank you guys very much for your opinions. Appreciate it.